cranial sutures. This can occur in isolation or in association with other anomalies. And here you can see different kinds of suture. And the most common are sagittal suture synostosis. Here you can see the sagittal suture are 3 times more common in the group of male. Coronal suture synostosis are less common. This suture, this kind of synostosis is slightly prevalent in a group of women. Here you can see, depends of the type of synostosis. We can observe this different shape of the head. For example, a sagittal suture synostosis leads to anterior-posterior skull elongation, is scaphocephalia, as you see here. Frontal suture synostosis leads to trigonocephalia, triangular skull, and coronal suture synostosis could be bilateral or unilateral, and in this situation we observe this kind of shape of the skull, so it could be brachycephalia or plagiocephalia, anterior or posterior. Here you also can see different kind of synostosis and how the head of this patient looks like. The timing and extent of procedure to realize the bones of the cerebral part of the skull depends on the type of the synostosis and the time of diagnosis. Cranial synostosis diagnosed before 6 months, a less extensive procedure is performed at 4-6 months of age. Cranial synostosis diagnosed after 6 months of age is associated with extensive treatments and is performed at 10-12 months of age or later. Cruzen syndrome. This kind of syndromes you should know. And one of them is Cruzen syndrome, is the most popular cranial synostosis. All the patients which you will see here during presentation are our patient treated in our department for many years. Autosomal dominant genetic disorder known as first branchial arch syndrome. Sutures of this infant skull fuse early, and the correct growth of the skulls is impossible. Common features: head, brachycephaly, very wide head, bulging forehead, eyes, exophthalmos, bulging eyes, as you see here, is connected with shallow eye sacs after early fusion of surrounding bones, and hypertelorism, so the orbits, the distance between the orbits is bigger than normal. Laryngologic problems, breath disturbances due to decreased dimension of airways. Very often this group of patients breathe through the mouth. Facial skull structure depends on the order of overgrowing of the cranial sutures. Brachycephaly is most often observed. Premature overgrowing of cranial sutures begins at 1 year of age and ends around 2-3 years of age. Sometimes they are already present in the perinatal period. What we observe: class 3 malocclusion, which is connected with underdevelopment of the upper jaw. So you can see here anterior crossbite, and here you can see bulging eyes and prominent forehead. Very typical for this patient is big like nose. Usually hypoplastic maxilla, and there's no problem with mandibular. The position of mandibula is correct. But when you look at the patient, it looks like he will have mandibular prognathis. But in fact, look at the diagnosis. We have skeletal class 3, and B minus 0.9. And SNA value is very, very small, as you see. SNB is also small. Oral cavity, palate high arched, so you can see it here. Narrow maxillary arch, and we can observe unilateral or bilateral crossbite. Very, very often crowding of the teeth. It's normal situation if we have narrow upper arch. This is typical situation. Very characteristic for this group of patients, ectopic eruption of the first permanent molars in upper jaw. We can observe it in 47% of cases. Here we also have this situation. So look, here we have first premolar, there was second premolar, but this first molar erupted under the distal surface of the second deciduous molar, and it leads to its resorption. That's why the patient lost too early deciduous molar. We also observe mesialization of the first molar. That's why we don't have enough space for the second premolar. You can see it on orthophantomogram, typical situation for ectopic eruption, first permanent molar. This is second deciduous molar. Look that here we have this surface was resorbed by this first molar, and very often we have this kind of situation that first molar resorbed the surface and erupt. Sometimes it couldn't erupt. In this situation, we should do make extraction of this second deciduous molar. Here you can see the same situation on this side, but in this situation we can see inclination of the first permanent molar, and the patient lost earlier the second deciduous molar. Patient has a huge problem with the place for these premolars on both second premolars on both sides. Next patient, upper syndrome, similar to Cruzon but more severe. Congenital disorders, autosomal dominant, first branchial arch syndrome, early fusion of the sutures of the skull disrupting normal bone growth. In some cases of this patient, we observe mental retardation. What is characteristic? What's the difference between Apert syndrome and Cruzon syndrome? Cruzon's upper syndrome is more severe, and characteristic is for this syndrome syndactyly. Syndactyly, it means that the patient has a fusion of digits. Facial skull structure, the coronal sutures fused before birth, only the lambdoid suture remains unfused. The circumference of the head of patient in the perinatal period is greater than normal. The same situation, the same characteristic feature of the face, like underdevelopment of the maxilla, big like nose, shallow eye sockets, bulging eyes, hypertalorism, strabismus, and low set ears. Low set ears is typical for many kinds of these syndromes. So even difference in not only in synostosis. So it's not characteristic part of only this kind of syndrome. In this group of patients, very often we observe class of the soft palate, 30% of cases. Of course, the same features like in Cruzon syndrome, so narrow V-shaped upper arch, crowding of the tip, anterior open bite, crossbite, and delayed tip eruption. Syndactyly, as I told you earlier, typical for this syndrome. So we observe fusion of digits of the finger of hand and also toes. Skin, acne vulgaris, spreading to the forearms during puberty and also later in 70% of cases. In this group of patients also we observe a reduction of the airway tract, and very often it's a problem with sleep apnea. Here you can see the airway tract. We can measure, and earlier we do it very often on the cephalometric X-ray. We measure this distance and this distance and check if they are correctly. Nowadays we have different methods to do it, so we don't use this method very often. It's not as good as different method, but we can estimate the width of the upper respiratory tract. Here I want to show you the comparison of this width of the upper respiratory tract in the different skeletal classes. So look, here we have first a skeletal class, and very and typical the airway tract for this class. Upper syndrome class, skeletal class 3, as you know, which is connected with the development of the upper jaw, very narrow airway tract, and Pierre-Robert sequence. Here also very wide, very narrow respiratory tract. Pierre-Robert sequence is connected with distal position of lower jaw. Cranial synostosis treatment. So usually we should prepare this patient. We should make alignment of the tip with a fixed appliance. As you know, we have under development of upper jaw, but remember that the suture in this group of patients fuse very early, and in fact typical expansion, typical treatment with face mask is impossible. That's why the patient needs treatment, for example, with this kind of appliance. It's extraoral appliance. It's a kind of distractor. We call this rigid extraoral distractor, and this distractor is connected with patient with the splint, which is connected with patient mouth, with patient upper jaw. And here is this appliance is connected with the screw with patient head. Typical patient with class 2, class 3 skeletal severe skeletal class 2 or severe skeletal class 3 needs operation. And to this operation in upper jaw, usually the surgeon, orthodontic surgeon, use Lefford 1 cutting. Is this cutting? In this group of patients, they need this cutting. It's Lefford 3. Why? Because they want to move all the maxillary bone forward. Rigid external distractor. So first we need osteotomy. I show you how it looks like. Then this appliance is mounted to the temples with usually 5 screws. Sometimes it's 3, sometimes it's 5. It's fixed to the maxillary bone. It could be fixed to upper jaw, as you see here, or to the splint, which is fixed to the tip in maxillary bone. So it's two possibility. Distraction is started on the 5th day after surgery because we have latency period, and range of distraction is 1 millimeter per day. In group of children before the spurt of growth, distractions lead to class 2 of angle. In older patients, to class 1 of angle. Why to class 2? Because we expect in this group of patients, in group younger patient before spurt of growth, we expect the intensive growth of lower jaw. That's why we should do pull maxilla much more forward than in norm. Okay, and the devices remains for 1-3 months due to the period of consolidation. Consolidation means it's a kind of maturation of newly formed bone. And bone remodeling takes place after removing the distractor. So it's the same method of working. This distractor as different kind of distractor. intraoral distractors. In the same way works also Hyrex. These appliances works like distractors. If we don't use distractor, we should, when we cut the bone, we should to fill this space with bone grafts. And bone grafts are usually take from the iliac crest in a part of the pelvic bone and are stabilized with adjacent growth with mini places you see here. In the case of distraction, the newly formed the space is filled by new bone. But remember that this during one day, if we make 4 activation of this distractor, we achieve 1 millimeter space. Here, the space is much more bigger during operation. But in some group of patients, the operation is impossible because the advancement of upper jaw is bigger than 10 millimeters. So in this situation, we couldn't expect correct healing, and we can even expect necrosis. And that's why surgeons decide on this method. First, patient needs distraction and then operation. As you see, this patient is after bilateral operation in upper and lower jaw. Intraoral situation after operation and extraoral photos. Growth disorders, achondroplasia. It's also called Parrot syndrome. 80% of cases are sporadic mutation. Very often, this syndrome is connected with the parent's age, especially father. This disease is caused by mutation in the gene fibroblast growth factor receptor 3. Growth disorders occur in synchondrosis of the base of the skull. In this situation, there is no correct translation of the jaw forward. So here you can see anterior cranial base. Here is sella turcica. Here is nasion point, as you remember from the supplementary analysis. So here you can see the synchondrosis. Some of the synchondrosis, like this one, stop the growth in the synchondrosis stops earlier. So in this synchondrosis, the growth stops around 7 years. So if there is correct growth, we observe also forward movement of the maxilla. Characteristic features: low height, megalocephaly, rhizomelia, shortening of proximal bows of lips bones, large cranial parts of the skull compared to the facial part, and frequent ear infections. Typical is in this situation large head with prominent forehead, underdevelopment of upper jaw. In the same situation we observe also in the first group of patients. Usually correct position of the lower jaw. Intraorally situation, asymmetrical dental arches, flat palate, underdevelopment of upper jaw, crossbite in anterior and posterior, very often bilateral. Most of the patient has hypotonic lips. Mandibular development disorders, Rachel Collins syndrome, or Franceschetti syndrome, autosomal dominant, craniofacial deformities involving ears, eyes, and cheekbones. Intelligence is usually normal. Craniofacial, the changes are bilateral and usually symmetrical, but not always. We observe very narrow face, flat infraorbital region. So this region, this is connected with hypoplastic zygomatic bones. Zygomatic bones usually underdeveloped. Sometimes there is a lack of them. Underdevelopment of the lower jaw, we observe also large mouth. Sometimes we see tongue-shaped areas on the cheeks, and hypertelorism is also in this group observed. Paranasal sinus is small. Sometimes there's a lack of them. Condyle and coronoid process on the mandibular are hypoplastic, or we observe the lack of them. Eyes, small eyelid gaps, and antimucoidal set. In 75% of cases, there's a dehiscence of the skin in one part of the outer lower eyelid. We don't see it here. It makes place here, and this is called coloboma. There's atrophy of eyelashes, may occur the absence of lower lacrimal points. Ears. Developmental disorders are a feature that is characterized in the 77% of this patient. Malformed and low-set auriculus, sometimes the lack of elements of the middle ear. The inner ear doesn't show deviation from the norm. The external auditory canal is narrowed, and in one part of the cases, there is no external ear canal. More than 50% of patients have significant hearing loss. There are additional outgrowths and blind fistulas between the ear and the angle of the mouth. Nose seems larger due to aplasia of zygomatic bones. Oral cavity, macrostomy. In 15% cleft palate or submucosal clefts. Ramus and body of the mandibular are shorter, and you can see it when you look at the patient that the formation of this bone is incorrect. Complete open bite and skeletal class 2 malocclusion. Dental abnormalities, subnumerality, vaginismus, and the development of non-tourniquets and microdontia. And here you can see also, this is on the orthopantomogram, distractor, but intraoral distractor. Distraction could be a lead also when the patient is growing. It's not only a method of treatment when the patient finishes growth, but it's a good method of treatment when the patient is still growing. Treatment. Removable appliances, upper and lower plates, the most often. Rather, functional appliances don't help this patient because we don't see a correct reaction on this appliance, because we have not only distal position of lower jaw to upper one, but we have incorrect development of ramus and body of lower jaw. That's why we couldn't treat this patient with appliance. We only change the position and help in growth of the upper jaw on the condyle. Patients need surgery treatment. Plastic surgery of the cleft is the first step of treatment. The next step is reconstruction of the zygomatic bones in the orbit. The operation is performed at 5-6 years of age, when the development of the craniozygomatic orbital complex is almost completed. The most complicated procedure is the treatment of mandibular underdevelopment of malocclusion. Many doctors recommend early mandibular distraction, which increase the dimension of the mandible and consequently increasing the volume of the upper respiratory tract. It reduces the risk of apnea in the child. Adult patients with moderate mandibular hypoplasia, mandibular osteotomy is performed in combination with genioplasty and osteotomy Lefort 1. In more severe cases, surgical procedure consists of the restoration of the mandible with cartilage grafts from the rib. Level 1 tip osteotomy is performed to correct the vertical, horizontal, and transverse malformation of the upper jaw. Ear reconstruction, so transplantation of autogenic rib cartilage at the age of 6 years. Hemifacial microsomia. In this group of patients, also we observe a problem with correct development of lower jaw. Its congenital disorders characterized by asymmetrical underdevelopment of structures derived from first and second brachial arch, upper and lower jaw, temporal jaw, zygomatic bone, temporal bone, ear, and soft teeth of the face are connected. This problem. Phenotypically, characterized with high variability. Most of problems occurs unilaterally, but in 12% of cases appear bilaterally, but more often unilateral problems. So if you look at this patient, you see bigger asymmetry on the one side of the face. What we see in the hemifacial microsomia. First, mandibular asymmetry. You can see it on this picture. TMG deformity. Of course, we should to have radiological examination to see it. And abnormal, very often, but not always, abnormal development of the ear, especially the extraoral pulp of the ear. Malformation of upper jaw, zygomatic bone, and temporal bone. According to Prushansky in cavern bonification, we have three types of this problem, and the difference is in the formation of TMG. Type 1, you can see it here, reduction of the size of mandible while maintaining its correct shape with a normal temporal joint. So it's not a very severe case. Type 2A, all structures, ramus, condyle, and temporomandibular joint are present but deformed, and symmetrical movements of the mandible are still possible. 2B, so this type, ramus, is significantly malformated and hypoplastic. There is no connection between the ramus and the temporomandibular joint, and in type 3, temporomandibular joint is aplastic and also ramus. And also the method of treatment in all these cases are different. In type 1 and 2A, we can treat this orthopedically or depending on the severity of defects by destruction or osteotomy. In the next two types, patient require complete reconstruction of the lower jaw TMG by the bone graft. Patient with sleep apnea or difficulty of swallowing needs distraction very, very early. Early distraction doesn't eliminate the growth potential of mandibula, but improved at an earlier stage the structure and function of mandibula. In early mixed dentition, treatment with functional appliances, we very often use in this kind of hybrid appliances, a special kind of modification of appliances. They could have acrylic biplane on the correct side, and on the opposite side a free surface and cheek shields. Clinically, an improvement in muscle balance and amplitude of opening is achieved during treatment with these appliances. In the most severe cases, reconstruction of the lower jaw and TMG is performed. Autogenic cartilaginous bone transplantation from the rib. The transplant used for temporomandibular joint aplasia not only improves the length of the mandibular ramus, but has growth potential, replacing the missing condyle process in patients before the growth spurt. Unfortunately, compared to the healthy side, the transplant growth in another unpredictable rhythm, often giving also asymmetry. But we still have function. And the girl with this kind of syndrome also, asymmetry is not huge, but look here we have typical for this syndrome a malformation of the ear. And here very severe case of the patient, huge asymmetry of all the face, not only lower part of the face, her cephalometric X-ray and PA X-ray and her ortho phantomogram. This girl needs orthodontic treatment. Here look what is typical, very small condyle on this side, and look here the neck of the condyle is much more longer. Goldenhar syndrome. The difference between this syndrome and the hemifacial microsomia is that here we observe also changes in the eyes, very often ptosis, so this is dropping of the upper eyelid, small eyelid gaps, and changes in the iris and coloboma. Next, Pierre-Robin sequence. This is here characteristic symptoms which you should know is micrognathia, cleft, secondary palate, and glossoptosis. Breathing problems occur immediately after birth, and this is explained by macrognathia and poorly developed muscular of the tongue, which collapses. Here, because of this sequence, why we observed it, I told you many times about this, that if there is a decreased volume of amniotic fluid, the fetus head, which is fixed, which is bended to the chest at 8 weeks, couldn't change the position to the more vertical. That's why the tongue, which has vertical position in mouth, couldn't change this position from vertical to horizontal. That's why the palatal shelves, here palatal shelves, which has also vertical position, couldn't change this position from vertical to horizontal because in this space is still tongue. That's why we don't observe the closure of the secondary palate, and we observe huge U-shaped cleft of the secondary palate. And as you see, this group of patients looks very different. We have very severe cases and moderate cases. Here, this patient will need surgery, and this girl looks almost good. This is our patient also with this kind of problem. It looks like a lot of patients with skeletal class 2. Here you can see visible huge scar after closing of the cleft of the palate. Treatment. Of course, surgical repair of the cleft palate. Very often, in the severe cases, distraction treatment with when we have significant underdevelopment of the mandibula. It's improved breathing, and sometimes the patient needs this very early, just after birth. Functional treatment during the spurt of growth with functional appliances, and in some cases, orthodontic treatment after 18 years of age. Adult syndromes, Down syndrome. In our department, we have a lot of patients with Down syndrome. The risk of having a child with this syndrome increases in mother after 35 years of age about 3 times and 38 times in mother after 44 years of age. Up to 33 years of age, the risk is about 1 per thousand. Cause of syndrome, the most typical cause of syndrome, I don't tell you about all of them, is total or partial duplication of the of one of the chromosome forming the 21st. Life expectancy is shorter because it's 35 years. Why? Because this group of patients usually have a problem with cardiovascular system. They have also problem with disorders of digestive system, dysfunction on the immune system, and of course everyone know that there is problem with delayed brain growth in the fetus and mental retardation. Characteristic features: craniofacial flat bridge of the nose, eyes, oblique eyelid gaps, epicanthus fold, brush-filled spots on the iris of the eye form on irregular ring around the pupil, ears. Malformation, not very often, but we can observe. Very typical for this group of patients is protruding tongue. What it means? This group of patients very often breathe through the mouth. The lips are hypotonic, incompetent. The tongue is bigger than normal, so there is not enough space in the mouth. That's why we observe this tongue that is keeping between upper and lower teeth. Also typical for this group of patients is narrow upper jaw, and a lot of dental anomalies we get observed. Neck wide and short, hands short, wide, short finger, single crease on the of the palms, simian crease and brachydactyly and clinodactyly. What is clinodactyly? We observe bent fingers. Usually, this group of patients has excessive mobility in the joints. Next patient. And intraoral situation. So, as you see, we have a lot. We don't have one typical malocclusion in this group of patients. We can observe clefts. Very, very often, 90% of patients has periodontal diseases. This is also connected with weaker function of the paranoid glands and breathing through the mouth. We observe caries very often. 75% of this person has delayed eruption of the milk and permanent tip. In fact, we have huge problem with this because very often I observe that the root of the permanent tip is fully developed, but the tip is, this tooth is still in the bone, and we wait a lot of time for eruption. Of course, we don't have a possibility to bring this impacted tooth into the arch, or sometimes even I see that the root is almost closed, but this tooth erupted, this tip erupted after even this time when they have a minimal potential of growth. Typical is hypodontia and atypical shape of the crown, and you can see it here, this atypical shape. The same shape we also see in ectodermal dysplasia in this group of patients. Treatment it depends from the kind of malocclusion and from the patient, because we couldn't give all the patient, we couldn't treat with all the methods this patient. because sometimes we have they don't cooperate this patient with us during treatment. So rather treatment with removable appliances. We have few cases of patients which we treat with fixed appliance. As you see, there is a huge problem with caries, and if we put them braces, we can expect that this patient could have bigger caries, and of course the treatment of the teeth is much more difficult. So sometimes they need a general anesthesia, and that's why we should to think about this when we are planning the treatment for this group of patients. Cleidocranial dysplasia. It is usually autosomal dominant, but in some patient the cause is not known. Different features of dysostosis are observed. It depends from gene mutation, but very characteristic feature is low height, short upper limbs, and vertebral abnormalities. Collarbones can be partly missing, leaving only the medial part of the mole in 10% completely missing. And the collarbones, if the collarbones are completely missing or reduced, this allows for hypermobility of the shoulders, including ability to touch the shoulders together in the front of the chest, and this you can see on this picture. Intelligence in this group of patients is typically normal. Skull open sutures of the skull, brachycephalic skull, large and short, prominent forehead. Secondary calcification centers appear along the line of the sutures and inserted bones, worm bones, and underdevelopment of the maxilla is very characteristic. We also observe hypertelorism. So you can, I hope that you remember that it's the next group of the patient with underdevelopment of upper jaw. So it was Apert syndrome, Cruzen syndrome, achondroplasia, patient with achondroplasia, and now cleidocranial dysplasia. Oral cavity, palate, highly arched. This patient may be known as much submucosal or full clefts. But what is the most characteristic in this group of patients? Here we observe a lot of supernumerary teeth, numerous cysts, impacted teeth, problems with eruption, malformation of crowns and roots. This malformation results from eruption problems very, very often. And our patient has 13 additional teeth. You can see CBCT examination and a lot of the teeth. There's a problem with exfoliation of deciduous teeth and eruption of permanent one. So what we should do? We should extract deciduous teeth and bring each one tooth into the arch. Pull it from the bone because this teeth don't want to erupt. And here you can see extracted teeth. You see that looks different. It has atypical shape. Ectodermal dysplasia, inherited diseases recessively with the X chromosome occur this most often, and ED is more common in the group of men. It could be autosomal recessive or dominant. Defects involving structures of ectodermal origin. We can distinguish anhydrotic and hypohydrotic form, and with the correct structure and function of sweat glands. Most common is hypohydrotic ectodermal dysplasia. Characteristic features are nails, sweat glands, and teeth abnormalities. Hair are usually very thin, light in color, and grow very slow. Nails, abnormal shape, discolored, and slow growing. squid glands, underdeveloped or abnormal function without normal sweat production. The body cannot regulate temperature properly, so we observe overheating is a common problem, especially during hot weather. Teeth abnormalities, hypodontia, microdontia, cone-shaped teeth, and enamel hypoplasia. In this group of patients, the most often we can expect anodontia in the group of deciduous or permanent teeth. It's not very common situation, but in this group of patients we can observe anodontia. Anodontia, I want to remember you that is a lack of the germ of all the teeth, so it's rather rare situation. Ectodermal dysplasia was divided into two groups, A and B. Group A, to recognize the defect, we should observe two of the listed characteristics from this. In the group B, one feature from this group, this list, and another symptoms of ectodermal origin. For example, changes in the skin to recognize it. Nowadays, of course, this patient has genetic examination to recognize this kind of syndrome. The skin is group of patient is thin, dry, with chronic eczematic problems, blonde hair, they get short, blue eyes very often lack of eyebrows and eyelashes, older appearance, yields malformation, characteristic satyr ears, longer in this part. Facial profile is usually flat and concave, because the lower part of the face is shorter. Why? Because the patient has lack of the germ of the teeth, so very often we don't see the correct height of the occlusion. The most often we observe malocclusion, class 2, and divide. Typical orthopontomogram of this patient. Look at the shape of the crown here. Maybe you will see also here, crown being shaped. And as you see, the patient is not very young patient, but still has a lot of deciduous teeth. So we observe here permanent and deciduous teeth. We don't make extraction this deciduous teeth because this person has not we don't observe the germ of the permanent tooth. That's why we leave this deciduous teeth as long as it's possible, because earlier we couldn't think about implantation, about denture bridges. Only we can think about dentures. Treatment depends on the age of the patient, the number of missing teeth, the condition of the milk teeth. So if we don't observe the resorption of the milk teeth, we leave it in patient mouth. Of course, for us is also very important the anatomy of the alveolar bone and the patient motivation to treatment. First, we use removable appliances. If it's possible, we make early correction of the bite. Very important is to maintain the height of the bite and secure excessive eruption of the teeth in opposite arches. Braces for teeth alignment we can use, and we prepare this patient for prosthetic restoration. For younger children, we can use children dentures, but they should be controlled every 3 months, and usually after 1-2 years we should change it for new one. For adult patients, we can use partial or total dentures, sometimes overdentures based on teeth or implants, sometimes bridges. Almost always before implantation, it is necessary to rebuild the alveolar bone. Już kończę. Ja zrobię Pani przerwę, dobrze? Okay, I will check the list once again and we will finish if I check it list. So wait a moment. Okay, thank you for attention. You can disconnect now. And remember that we have last lecture in the next week.